Hope Cook with Dermcast TV. Today I have Dr. Hillary Baldwin. Dr. Baldwin is a board-certified dermatologist. She's also medical director of the Acne Treatment and Research Center in Brooklyn, New York. She is also a clinical associate professor of dermatology at Rutgers Robert Wood Johnson Medical Center. Welcome, Dr. Baldwin.
It's my pleasure to be here. Thank you.
Yeah, I'm excited about learning more about acne and rosacea.
Okay.
So will you start off by telling us the four-pillar approach to treating acne?
Sure. We know a lot about acne pathophysiology. Mostly in the last 10, 15 years, things have sort of come into focus. And we recognize that there are four separate pillars. There's an increase in sebum production, which occurs at puberty under the influence of the increase in androgens. There's follicular hyperkeratinization, where the inside of the hair follicle basically gets all clogged up with epidermal cells and sebum and such. We have an increased colonization of C. acnes, the bacterium that lives in the follicle, as well as an increase in the inflammatory process. And the concept of treatment involving these four pillars is that the more of them you hit, the more you can affect each one of those, the better the ultimate treatment is. We know that, for example, the average successfully treated acne patient is on 2.53 different medications, right? So you want to pick one from column A and one from column B, and if possible, one from column C and one from column D. Put them all together, and you have the best possible treatment. We have one drug that does that itself, Isotretinoin, which has all four pathogenic pillars.
Yeah, and you mentioned like primary care doctors will sometimes send patients over to see us and they're on topical clindamycin and
oral minocycline or something like that. They've picked the same pillar because perhaps it's something that they're comfortable with. They know which drug to pick, but two from the same pillar doesn't make any sense at all. You want to be attacking acne from as many directions as possible. Unclog the pore, reduce the sebum, kill the bacteria, reduce the inflammation, and you have yourself a winner.
Do you try to go over that with patients, or do you have a handout? Or?
I actually do. I mean, because you can't take the teacher out of the girl. So I have a simplistic version, of course. I separate the paper into four pieces, the one pillar in each one. I wouldn't say dumbed down, but simplified, lay terms, of course. And then I enter into it the medications that we're going to be introducing that day so that they understand why. And then I put that, I used to put it in their chart. Now I scan it into their chart so that the next time they come in and say, okay, well, this is what we did. And as you notice, your blackheads are a little bit better. So that retinoid doing its job.
I love that.
But your inflammatory lesions not doing all that well. We're going to have to, increase up our ante in that regard. I think they take to that very well. It's more likely that they're going to realize that I haven't given them multiple medications as a plot to destroy their lives.
Yeah.
I've done it for a reason, and each one of them plays a role. And as a matter of fact, removing one of them could be deleterious to their response.
Yeah, and it seems like they would take more ownership of their treatment.
Completely agree.
Yeah. And then does it also help when you see isotretinoin in every category?
Yes,
does
it
that
does.
help persuade parents?
Yes, they really get it. Of course, we call it Accutane when we do that because they don't know from isotretinoin. But yes, when I put a gigantic scarlet A in each one of the boxes, they recognize, oh, okay, that's why my precious junior needs to be on this medication that the internet tells me I have to be concerned about.
Speaking of the internet, how has that changed your practice with social media and kids watching TikTok? And
it's always been a problem, but it's coming from a different place. And I remember, in the 80s when we were practicing paleodermatology, when there was no social media, kids were still using toothpaste to make their acne. Still.
I remember that.
And it happened to me just the other day. Things haven't changed. It's just the way in which they've been told about the toothpaste. And tomato paste.
Oh, I have not heard
Yeah,
that.
that looks really great on skin. So, and the whole concept of diet. And so the myths still persist. They're just coming from a different location. The one that drives me the most crazy, and tell me if this one drives you crazy too, is drinking more water.
I have not heard that one.
Yes. Oh, well, they say it as an excuse. I know this is my fault. I should be drinking more water.
Interesting.
First of all, acne is not your fault. And second of all, the only person that benefits from you drinking more water is the bottled water industry.
That's right.
It's all a gigantic conspiracy, it seems to me.
All right, so what are some of the most common mistakes you see new providers with acne and just things they forget to tell patients? Or
That's a really good question. I suppose the biggest mistake that all of us make, regardless of how long we've been in practice, is not educating the patient enough. But we've sort of already reviewed that kind of thing. You cannot educate a patient too much. I think that it's very important to tell them that they're going to have the potential side effect of the drug you're giving them. And then if they don't, everything's cool. So, prepare for the worst and hope for the best. You're going to be dry, you're going to be irritated, and then when they come back, well, it wasn't as bad as you said. Oh, isn't that nice? You know. So under-educating is crucial. Not picking from enough categories is crucial. Relying too heavily on antibiotics in general.
yes.
I think we feel more comfortable with oral antibiotics than we do with some of the other medications, but we're responsible for a huge chunk of the antimicrobial resistance that we're seeing now. And we need to stop doing that.
Yeah.
So looking for non-antibiotic approaches, which often requires more medications and working a bit harder, but well worth it in the end, and make sure that you're explaining to the patient, I could just cop out and give you an antibiotic, but that's not good for you and it's not good for the world.
And you said that, a long time ago, the thought was P. acnes needs to be eradicated.
Right.
Can you say more about that?
Can't be. It lives in the follicle. You can decrease the numbers temporarily, but unless you do something else, the numbers will come right back up again. So people will say they failed a course of antibiotics. Everybody fails a course of antibiotics for acne, not for pneumonia or something, right? But for acne. You decrease the numbers, you come off of it, the numbers go right back up again. So you have to intervene when the numbers are low. So what that means is starting the drug that you're going to use at the same time as the antibiotic, so that when you're finally able to stop the antibiotic, the other medication has kicked in, whether it's spironolactone or a topical retinoid that needs 8 weeks to really get up to speed, or a topical clascoterone, which needs almost a month to get up to speed. 12 months. Let me say that again. 12 weeks to get up to speed. It's a little bit slow, just as spironolactone is, right? So you need to start everything in the beginning so that when you're ready to stop the antibiotic, they have a fighting chance.
Yeah. Do you still use oral antibiotics?
Yeah.
Okay.
I do. You can't treat acne without it, can you? And it also depends on the time for the patient. I mean, when a patient comes in, I'm getting married in 2 months. Prom is in 2 months, and my back is covered. Of course, there's nothing else that's going to make them better in 2 months. And I have no problems putting somebody on an oral antibiotic at that first visit, as long as I'm also treating them with the medications that we're going to use for the maintenance phase. The trick is to get them off of it as soon as you can. And that does not necessarily mean waiting until they're 100% better.
Yeah.
50 or 75% is probably good enough.
Do you generally do it 8 weeks or?
I generally do it whatever I need to do.
Okay.
And hopefully that'll be a month. It may be 8 weeks. It may be 3 months. It may be longer, to be honest with you. Sometimes the patients are doing so well, and maybe now the wedding is only 3 weeks away. Well, of course I'm going to continue it, right? So I do use them, yes. I just try to be, I always use them along with benzoyl peroxide and a topical retinoid. They're never as a standalone.
And you also showed an interesting study about benzoyl peroxide. And can you say more about that?
Benzoyl, it's 60 years old, and it's still, I couldn't live without it in acne land. In its own right, it's an excellent treatment for inflammatory lesions of acne, and to a lesser extent, non-inflammatory lesions. But perhaps more importantly, along with either topical or oral antibiotics, it prevents the development of resistant organisms. So anytime you prescribe a topical or an oral antibiotic, benzoyl peroxide should be part of that equation. Now, lots of people say, well, I'll just throw them a cleanser. Well, cleansers are better than nothing, but cleansers, at best, are about 10 log less good than a leave-on benzoyl peroxide at killing C. acnes. So better we find a way to give them a leave-on than to give them a cleanser. But again, cleansers are better than nothing.
And do you sell it in your office, like an over-the-counter benzoyl peroxide?
I sell nothing in my office.
Okay.
I have found that I myself can't handle it.
Yeah.
I just can't. Whenever a patient says, should I use this or that, and the medicine calls to me from the closet saying,
that.
use me, sell me, I can't do it. I ended up not selling because I felt so uncomfortable about selling, so I don't do it.
Okay, and then it also surprised me when you mentioned brand names versus generic.
Yes.
Do you mind sharing your take on that?
No, I'm a brandaholic, and not in everything. I mean, everybody thinks that I'm a brandaholic for everything, because mostly I talk about acne and rosacea, but in other conditions, I'm not. I'm a generic user. I wholeheartedly believe in reducing the cost of medical expenses in the United States, but rosacea and acne medications are terribly sensitive, and these medications are very caustic. And unless we find a way to balance tolerability and efficacy, we're going to fail. And these patients come in to see me who have failed the very same medication they've failed. They're a success with me. What, because I've got like fairy dust that I sprinkle? No, because I went from a generic to a branded product with a beautiful vehicle that has maintained efficacy and reduced tolerability. So guess what? They actually used it, and they got better because of that. So I just think in acne and rosacea land that it's very important to have a tolerable product. Now that might be generic. For some people, they can tolerate generic versions, but not everyone can.
Yeah, that was an aha for me, but the more I thought about it, it does make it friendlier to use on your face.
Exactly.
Especially if you have something inflammatory.
Precisely.
Yeah. Okay, so switching gears to rosacea. Tell us your tricks with rosacea. Do you still do the 4 quadrants? How do you?
No, I spend much less time talking about pathophysiology with rosacea. In fact, I probably don't talk about it at all. I talk about the multifaceted appearance of rosacea. And I hand the patient a mirror and have them take a look at themselves with a nice bright light. And I say, okay, so your little red circles on your red eyes, that's probably rosacea. You have some pimples over there, you have some fixed telangiectasias here, you have some background erythema, whatever it is that I see. I point out each and every single one of those, and I ask them about their symptoms. Do you burn? Do you sting? Your itch? So now I have everything that I need to make a comprehensive recommendation for a regimen. Now that regimen includes making all of that stuff better. But the bottom line is that not every patient wants all of those things to be better in general, and especially may not want them all to be better when they find out that in order to do that, they have to be on 2 creams, a pill, and fork over a couple $1,000 for an energy-based treatment. So we point all those things out. Which one do you care about the most? Where should we start? What else do you want to treat after we've started on that? Okay, treatment of this will require X, Y, and Z. And it will cost money or it won't cost money. And then we move on from there, because you need to get the patient buy-in. If you have somebody who stings and burns with sad sac eyes and pimples and erythema, that's an expensive proposition for them. And it's time consuming. It basically is going to be their entire job every day. So you need to get their buy-in. And not only will it be their job every day, but it will be their job every day for years.
Forever.
Right.
Yeah. I like that because a lot of patients may want to know, they want reassurance, I'm not going to get the big nose.
Right.
You know, and maybe they only have the little blood vessels.
Yes. You know, the big nose is interesting because I've found that it's very important to tell a woman that it's highly unlikely that they're going to get a rhinophyma.
Yes.
Of all the things that I say in my office, that moment requires the tissue box more than any other. When the woman says, oh, thank God, I thought I was going to look like my Uncle Pete or whatever it is. And they actually start to cry because I've told them they're not going to have something they thought they would. So it's very important to actually mention that to a woman. Very rare that they get rhinophyma, which is kind of interesting. And I don't exactly understand why that is. Yeah. But yes, you need to inform them about every single aspect of their condition and ask them if they care. I've had people who are bright red and they don't even seem to notice, much less, I can make that better. My mother looks like this, my sister looks like this, I always look like this.
Yeah, I don't have to wear blush.
Right, I know, but I mean sometimes it's really quite lobster red, and they don't care, whereas I would care like crazy. So again, the mirror and asking them what they care about is crucially important. What I care about, if my face looked like that, is completely unimportant.
That is such a good point. All right, Medicare patients, do you have, I know, because of the brand names are not going to be covered.
That's incredibly important in rosacea land especially. Fortunately, we have quite a few products that we can use in our Medicare patient for papules and pustules. We can utilize generic antibiotic preparations. Usually I don't like to use full dose antibiotics. This is not an infectious condition. I don't want to be adding to the issue of antibiotic resistance for a rosacea patient especially. But you can usually get 20 milligrams immediate release and 20 milligrams twice a day, separated morning and night, not together. Works almost as well as the 40 milligram modified release version.
Of doxycycline.
Ivermectin now is generic and usually relatively affordable. So those two are my go-to.
Okay, that's a good tip. Do you ever do over-the-counter sulfa wash or prescription sulfa wash?
No.
Okay.
Do you?
I'm not on this. No, I never do.
I don't find them to be particularly helpful.
Yeah.
But, you know, I'm an old lady. That's all we had when I was starting out in dermatology. And then they disappeared because they didn't work very well. And then I'm not sure why, but they came back.
Seems like it's something to offer, but
well, yes.
Slightly better than nothing.
Well, that's exactly it. And if I'm making a recommendation for a product because it's either that or I have to say there's nothing I can do for you, you know, that's not exactly a rousing endorsement. And I imagine I would in that situation because I hate to say I can't help you.
Okay, what about the correlation with the gut? Do you get that question all the time?
I do indeed, but not for my patients. It hasn't seemed, at least in my experience with my patient population, hasn't hit mainstream yet for them. But I'm asked it all the time by colleagues. I do think that there is a relationship in some patients. It's not common enough for me to necessarily query my patients as to whether or not they have gut issues. I have put in my intake form, though, a more comprehensive gut question. So it used to be just sort of, do you have any GI issues? And now it's more specific to bloating and gas and constipation and diarrhea. And I've been much more specific about it. And I do glance at that. And if it's a positive review of systems, then I'll discuss it. But you know, we have a limited amount of time to care for our patients, and education is so important. I don't want to bring up a subject where I have no answer, and open up a can of worms that's going to end up taking time away from something that is perhaps more important.
Yeah.
So only in the patient where there's an actual rationale for doing so.
And the psychology of acne and rosacea can already be hard enough, and then if you throw on top of that, this may be your fault because of what you're eating,
That
or
is
you imply that.
such a great statement. That I could not agree with you more. Every time we say that you're not drinking enough water, my personal favorite, or you have acne because you eat junk food, or you have rosacea because you drink red wine, we're putting the blame on the patient. And could that possibly be a trigger? I guess so, but quality of life matters as well.
Yes.
And blaming a patient for their own disease is just dirty pool.
Yeah, I agree. All right, lastly, tell me about how do you get to the root of how much a patient's acne really bothers them? Like, what kind of questions do you ask?
You have great questions. I have to say, I've never been asked these great questions before. I ask every acne patient on a scale of 1 to 10, 1 being what acne, and 10 being, I come from Brooklyn, you remember that part, right? 10 being, get this crap off my face or I'm going to stab you. I literally say those words.
Like that.
You can change it to whatever you like. Change it to whatever you like, whatever works in your neighborhood. That works in Brooklyn. And how do you feel about your acne? And my opinion is that if they are below 5, we've got ourselves a problem, because it's highly unlikely that they're going to be adherent to even 1 treatment, much less the 2.53 that I want them to use. I think it's also sometimes interesting to separately ask mom the same question.
That is a good point.
Mom is frequently at 10 when the kid's at 2.
Yeah.
Sometimes the opposite occurs. Mother is just doesn't care. I had acne when I was a kid. I got over it. You will too. And it doesn't even make it to her radar screen, whereas the child usually in that situation, a young woman perhaps with body dysmorphic disorder is at a 10, even though she only has a couple of pimples. So it's a very important question to ask to see where they are, and if they're about to tip over the edge. You know, I mean, people who are at 10, for example, and have 3 papules are in trouble.
That is a good point too.
Right, so that simple question really helps you to decide whether they're going to be adherent to therapy, how many treatments you can use, how fast the medication needs to work, how crucial it is to make the patient better as fast as possible, and whether or not you need to intervene with a very, very big disconnect between mom and the child.
Yes, excellent advice.
Thank
you so much, Dr. Baldwin.
My pleasure. This has been a lot of fun. Thank you.
Good. Hope Cook signing off for Dermcast TV.